Okay, then I'll revise in a very short bit and then continue from where I left. So we were talking about Parkinson's disease. Parkinson's disease, which is mainly characterized by following hallmarks, which is slowness of movement, bradykinesia, rigidity, tremors, and postural loss of postural reflexes. So James Parkinson's initially coined the term Parkinsonism as shaking palsy in 1817, with a very low incidence of 18 per 1 lakh population, equal incidences in males and females, and the age of onset is usually more than 60 years. So it's a disease of elderly. Parkinsonism is classified under idiopathic, secondary, and neurodegenerative disease. So, idiopathic, the most common form, constitutes 80% of the disease. Secondary Parkinsonism has n number of causes we are going to discuss ahead, and neurodegenerative diseases, also known as Parkinson plus syndromes. So this is as far as etiology is concerned. Idiopathic Parkinsonism, most common, 80% of the cases. Then secondary Parkinsonism because of drugs and toxins, degenerative diseases, and genetic predispositions. So drugs and toxins mainly antipsychotic drugs, metoclopramide, prochlorperazine, tetrabenzene, sodium valproate, lithium, manganese, and methylphenyl tetrahydropyridine. So you realize antipsychotic drugs, they tend to reduce dopamine in the body. So antipsychotic drugs are the most common cause of Parkinsonism, drug-induced Parkinsonism. Again, the drugs like prokinetic drugs, metoclopramide. Generally, the patients taking pantoprazole with levosulfide for a very long period of times are predisposed to develop Parkinsonism. Again, the patients who take domperidone very frequently as antiemetics are predisposed to develop Parkinsonism because they tend to reduce dopamine in basal ganglia. So it is only the interplay of dopamine, acetylcholine, and excitatory and inhibitory transmitters, which leads to development of Parkinsonism. Whenever the inhibitory transmitters take over the function of excitatory neurotransmitters like dopamine, or there is a relative decrease in production of dopamine, or there is inhibition of function of dopamine, it leads to Parkinsonism. Then this subset of diseases, dementia with Lewy bodies, multisystem atrophy, progressive supranuclear palsy, corticobasal degeneration, all these subsets of diseases are classified under Parkinson plus syndrome. So there is Parkinsonism as well as something more to it. Then there are genetic predispositions due to Huntington's disease, spinocerebellar ataxia type 3, Wilson's disease, fragile X-remor ataxia, anoxic brain injury, anything which affects basal ganglia leads to development of Parkinsonism. So here we come and discuss about the secondary Parkinsonism. So secondary Parkinsonism, the disease processes which affect the basal ganglia like infectious post-encephalitic changes by HSV encephalitis, HIV, subacute sclerosing panencephalitis, Trion's disease, drugs like dopamine receptor blocking agents, rezapine, tetrabenzene, alpha-methyl-dopa, lithium, flunarizine, cynarizine, domperidone, all these drugs they lead to secondary Parkinsonism. Then toxins like MPTP, carbon monoxide, manganese, mercury, carbon disulfide, cyanide, methanol. Vascular, multiple small infarcts surrounding the lateral ventricles, also known as Binswanger's disease. Then trauma, then parathyroid abnormalities like hypoparathyroidism leading to calcification of bilateral basal ganglia. Then hypothyroidism, brain tumors, paraneoplastic syndromes due to anti-mu antibodies, normal pressure hydrocephalus, and psychogenic conditions. So basal ganglia consists of choric nucleus, putamen, lobus pallidus, subthalamic nucleus, substantia nigra. So all these parts of basal ganglia, they function in series and they receive and transmit impulses from cortex, from sensory cortex to motor cortex, and then coordinate the whole movement of body, the basal tone and the postural movements of body, smooth movements. Balance of 5 large subcortical nuclei are responsible for smooth motor movements. So primary input from cerebral cortex and the output directed through thalamus back to prefrontal, premotor, and motor cortex. So this circuit is very complicated. The only thing for you to understand is dopamine from substantia nigra gets decreased. So it ultimately decreases the release of acetylcholine from striatum. So it leads to increased neuroinhibition. Increased neuroinhibition in basal ganglia leads to increased tone, increased rigidity, and difficulty initiating movements, bradykinesia. So in the interplay of excitatory and inhibitory transmitters, the excitation gets decreased and neuroinhibition takes over, leading to slowness of movements, rigidity, and bradykinesia. So here's the pathophysiology. Any insult leading to damage of basal ganglia substantia nigra then leads to destruction of dopamine producing neurons within basal ganglia, reducing the amount of available striatal dopamine. So inhibitory effect ensues. There is increase in acetylcholine. So excitatory effect of acetylcholine is inadequately balanced. There is difficulty in controlling and initiating voluntary movements. So the smoothness of movements is lost. Pathological hallmark of Parkinson's disease are these inclusion bodies, which are Lewy bodies, which are neurodegenerative presence of small synuclein protein, which get included inside the cell bodies of axons of basal ganglia, substantia nigra, also known as Lewy bodies. So these are neurodegenerative bodies, which are the hallmark of Parkinson's disease. So clinical manifestations include, in the beginning, the patient suffers from mild resting tremors. There may be slight limp in the gait with forward bending, short steppage. There is decreased arm swing. Patient tends to keep his arms flexed and close to his body. Then on the later stages, the patient suffers from shuffling of gait, also known as festinant gait. He tends to propulse forward very quickly. Then with his arms flexed, he is unable to maintain the posture and he has propensity to multiple falls. There is loss of postural reflexes. There is also the change in speech pattern. The speech becomes monotonous and low-pitched. So out of 4, 3 must be satisfied in order to classify the patient into Parkinsonism. Number 1 is unilateral onset. The disease to start with usually affects either right upper limb or right lower limb or left upper limb or left lower limb, gradually progressing with asymmetry, and is usually asymmetric till the end, till the burnt out disease, when the patient develops complete bradykinesia and loss of control of his reflexes. So unilateral onset, persistent asymmetry, presence of resting tremors. The tremors at rest, which are involuntary, small 3.5 hertz frequency around. So the patient has pill rolling type of tremors and the disorder is inadvertently progressive. You cannot stop or cure the disease, you can only delay the progression. So this is a picture which shows an old man who has a festinant gait. He has tendency to bend forwards with pill rolling tremors in his right hand. Then shuffling gait, unbalanced small steps. Our patient is bent forward, also known as festinant gait. So classic clinical manifestations include tremors, which are the first sign of the disease, these small involuntary resting tremors lead to disturbance in handwriting, leading to micrographia. The patient's letters become small, cursive, the patient's handwriting becomes increasingly slow, and there are non-intentional tremors which are present during rest and present usually in awake condition. They vanish during the sleep. The characteristic name given to such tremors in hands are they are called pill rolling tremors. Then rigidity. Cogwheeling rigidity, like a ratchet, like there are jerky movements with increased tone when you try to flex and try to extend the limb passively. The patient suffers from jerky movements throughout the range of passive range of motion. So increased resistance and jerky movement while opening and closing the joint. So these are the part of rigidity, cogwheel rigidity. Then bradykinesia. Of course, the slowness of movement, difficulty in initiation of movement, difficulty in initiation of speech, difficulty in initiation of any activity, and then slowness of movement, difficulty in completing that activity. Postural instability, like changes in gait. The patient tends to bend forward, walk on toes with small shuffling steps. Then, once initiated, he may accelerate almost to trot and then has propensity to fall. Changes in balance. The patient has stooped posture, over posture when erect. Difficulty in maintaining balance and sitting erect. Cannot right or brace self to prevent falling when balance is lost. So the balance is lost, the posture is distorted, and patient has repeated propensity to falls. Secondary manifestations which could be expressionless face, mask-like faces. The patient may have eyes stare, which is right above the head. The patient may have a staring gaze. Blinking is decreased. Speech problems like low pitched speech, low volume, slurred and muffled words, monotone, difficulty in starting the speech and finding the words. So paucity of speech. Then fine motor functions, like we've already discussed, micrographia, handwriting becomes small and cursive. There's clumsiness, decreased coordination, freezing, sudden involuntary inability to initiate the movement can occur during movement of inactivity. So this is an example of a patient of Parkinson's disease in his handwriting. So you are barely able to identify any words in that. So this is micrographia and Parkinson's disease handwriting. Autonomic disturbances. Autonomic disturbances affecting bowel like constipation, hypomotility, prolonged gastric emptying time. There is urinary frequency, urinary hesitancy, orthostatic hypotension. The patient may develop fainting and dizziness while suddenly getting from the bed. Then dysphagia, neuromuscular incoordination, drooling resulting from decreased ability to swallow. So all these autonomic disturbances are also the part of later burnt out disease. So again, this picture shows a person with Parkinson's disease with typical appearance of stooped posture. The patient has bent forward posture, mask-like faces, forward tilt of trunk, reduced arm swing, keeping the arms close to the body, slightly flexed knees and hips, shuffling short stepped gait, trembling of extremities, pill rolling tremors, flexed elbows and wrists, rigidity. So all the unmasked like faces, mask like expressionate face. So all these are the features of Parkinsonism described in a person. So talking about the Lewy body dementia, as we talked about Parkinson plus syndrome, something which is more to Parkinsonism. Superadded on Parkinson's disease, there are 4 clinical syndromes which have been identified as Parkinson plus syndromes. Number 1 is Lewy body dementia, then it leads to visual hallucinations, cognitive dysfunction, motor dysfunction, autonomic dysfunction. The patient tends to act out in dreams during REM sleep and other sleep disturbances. Upward gaze palsy. All these are features of Parkinson plus syndrome Lewy body dementia. So we must understand that diagnosis is purely clinical. The role of investigation is only limited to identify Parkinson plus syndromes. So Parkinson plus syndromes like Lewy body dementia, corticobasal degeneration, multiple system atrophy, and all these are the Parkinson plus syndromes. Progressive supranuclear palsy. So Parkinson's disease, the current therapy aims at increasing the dopamine in the basal ganglia substantia nigra. So either by giving levodopa with decarboxylase, peripheral decarboxylase inhibitors, or MAO-B inhibitors, monoamine oxidase inhibitors, catecholamine methyltransferase inhibitors. So all these, they increase the concentration of dopamine in substantia nigra, or the drugs which mimic dopamine action. They act on T2 receptors, so they do T2 agonists, then dopamine releasers, then MAC antagonist. That means muscle acetylcholine antagonists. So pharmacological therapy includes dopamine agonists, MAO-B inhibitors, monoamine oxidase B inhibitors, catecholamine methyltransferase inhibitors, levodopa with carbidopa, amantadine, anticholinergics. The patient needs to be educated about the progressive nature of this disease, and in certain cases, not in India, but deep pain stimulation has been tried when the drug's effect fades out. So drug therapy against Parkinson's disease is aimed at bringing the basal ganglia back to drug therapy against Parkinson's disease is aimed at bringing the basal ganglia back to balance. So decreased cholinergic activity within basal ganglia, this can be done in 2 ways: by activating dopamine receptors in substantia nigra, feeding back to cholinergic cells in striatum, and turn off the cholinergic cells, then things are brought back to balance, or to antagonize acetylcholine receptors. So centrally acting anticholinergics like benhexol and trihexyphenidae, they are centrally acting anticholinergic drugs apart from dopamine, which are used in antipsychotic induced Parkinsonism. So agents which to increase the dopamine function are levodopa, we use it along with peripheral decarboxylase inhibitors to increase its blood-brain barrier penetration and increase concentration in brain to prevent the peripheral decarboxylation of levodopa. Then, by inhibiting the catabolism of dopamine, like drugs like selegiline, which are MAO-B inhibitors, by stimulating the dopamine receptor sites directly by agonists like bromocriptine and pramipexole, and blocking the uptake and enhancing the release of dopamine by antimetabolites like amantadine. So pharmacological treatment in Parkinson's disease can be divided into symptomatic and neuroprotective or disease-modifying therapy. So levodopa coupled with carbidopa, a peripheral decarboxylase inhibitor, remains the gold standard of symptomatic treatment for Parkinson's disease. Carbidopa inhibits decarboxylation of levodopa to dopamine in systemic circulation, allowing the greater levodopa distribution into central nervous system. Levodopa provides greatest anti-Parkinsonian benefits for motor signs and symptoms, with fewest adverse effects in short term. However, the long-term use is associated with development of motor fluctuations like wearing on and off phenomena. Like in the later diseases, when the patient takes the drugs, the patient is relieved of symptoms. Otherwise, during the periods of fading of drug concentration from the blood, the patient develops the symptoms again. So there is on and off phenomena in the later cases. So levodopa is usually given in TDS doses or QID doses. In more advanced states, the patient may cycle between on and off, complicated by disabling dyskinesias and off periods, which they suffer severe Parkinsonism. Then monoamine oxidase inhibitors can be considered for initial treatment of early disease, like selegiline and rasagiline. So you use levodopa to start with, add with monoamine oxidase inhibitors, and then when the disease progresses, you may add dopamine agonists and metabolic treatment like amantadine. So dopamine agonists like bromocriptine, non-ergot derivatives like propanol, pramipixole provide moderate symptomatic benefit. They enhance motor functions and reduce off time when the drug fades off and the levodopa concentration fades off in time. So they cover up in that period of time. So they are relatively long-acting and less prone to induced dyskinesias. And COMT inhibitors like anticapone and tolcapone, they increase the elimination half-life of levodopa, enhances its brain availability. Combining levodopa with COMT inhibitors also reduces off-time and prolongs on-time. On-time is the time when the drug stays in blood and leads to normal functioning. Off-time is when the drug fades off from the blood. So neuroprotective therapy it aims to slow, block, or reverse the progression. Such therapies are defined as neuroprotective therapies. So you need to actually protect whatever dopamine-producing neurons are there in the body. So all these neuroprotective therapies are under the study. So they are under trials. Other agents currently under investigation include coenzyme Q, MAO-B inhibitors, some second generation MAO-B inhibitors, creatine and isradipine. So when to suspect a patient with Parkinson plus syndrome? When a diagnosis of Parkinson's disease is made and treatment has been started, but the condition is poorly responsive to adequate treatment of Parkinson's disease, even in the early stages of disease, then you must look for the signs and symptoms of degeneration of other neuronal systems also. So if a patient presents with following symptoms, you must consider the Parkinson plus syndromes like this. If a patient develops falls as early symptom, then you must consider progressive supranuclear palsy. Then prominent orthostatic hypotension right from the start leads to the suspicion of multisystem atrophy. Then early dysarthria, if patient has, then you must consider multisystem atrophy. Then lack of tremors, but only bradykinesia. You must consider various Parkinson plus syndromes like Lewy body dementias, and early hallucination dementia as first symptom. Then again consider Lewy body dementia, alien limb phenomena. Then again consider corticobasal degeneration. Thank you.